Good evening. I'd like to welcome everyone here. I'm Joan Stauffer, and I manage clinical education programs at Iridex. It's my pleasure to introduce our panel for tonight's MicroPulse workshop. Dr. Bert Glaser is the founder and executive director of the National Retina Institute in Towson, Maryland. He's here along with his colleague, Dr. Khurram Malik, from the NRI's Chevy Chase and Falls Church offices. And I'd also like to introduce Dr. Appiah from Capital Eye Consultants in Tallahassee, Florida. We appreciate their time being here to share their experiences using MicroPulse. And with that said, let's begin with Dr. Glaser, who will first talk about new paradigms for the role of laser in the treatment of retinal disorders. Dr. Glaser.
I want to thank Iridex for allowing me the opportunity to talk about this topic. I think it's really one of a great deal of interest for all of us. And I think really what it brings to the forefront is that there's a new paradigm developing for the role of lasers in retinal disorders. I think the way we've been thinking about it is probably wrong, and I think we're going to be developing new paradigms, new understandings. It's going to expand our ability to take care of our patients. Disclosure: I have no conflicts of interest. I am not a board member, a stockholder, an owner of Iridex. Ted Budakoff is not my long-lost brother-in-law, and I'm not getting any honorarium. Although it was offered, I'm not accepting it, so that I have no conflict of interest at all. How does laser work? I mean, that's really the mystery. It does stuff, but we don't understand how it works. So if we go back a little bit to understand really where it began, a lot of modern day lasers really started out with Aiello and Beetham, or Beetham and Aiello. And they observed in the 50s and 60s that patients with chorioretinal scars who had diabetic retinopathy had neovascularization maybe in the eye without scars, but if there were scars in the eye, they were protected against developing neovascularization. So they got the idea that you could probably never do today again because of the medical malpractice lawyers, et cetera. But they said, well, let's create chorioretinal scars in a bunch of diabetics, and let's see if they really get protected. It turns out they did, and they used the ruby red laser. And why is that important? Well, it's important. I'll come back to that's important. But remember, they used a ruby red laser in that day. Well, the question was, how does laser work? It's been a dilemma. There's been the idea that it increases retinal oxygenation, or it destroys factor X, Michelson's factor X, which probably is VEGF plus a number of other growth factors that we don't yet know or understand, and it destroys those producing cells. Those were two of the principal ideas. Well, the idea of increasing retinal oxygenation, it may do that, but whether or not it really has a role in the efficacy of laser treatment is still a mystery. And after 50 years of that hypothesis, there's really no significant proof that that's doing anything. Does it destroy cells that produce factor X? Well, we don't know, but let's go back to the ruby red laser issue. Ruby red laser caused very, very minimal scarring. As a matter of fact, when you saw, I'm old enough to have seen many of those patients. There may be one or two other people in this audience who are old enough to have seen some of those patients who were treated with ruby red laser, and you could barely see the scars. As a matter of fact, you had to do a fluorescein many times to see them. But so it was barely visible back then. So maybe that was the first subthreshold laser. And then we did argon, but we also did xenon. And it turns out, and xenon caused hugely heavy, massive laser scars. It turns out that mild laser was no worse or no better than heavy laser. So right there you begin to wonder what the role of these killing cells is. Well, back in the mid-'80s, we presented some data looking at retinal pigment epithelial cells in culture, and we found that they could be induced to release an inhibitor of neovascularization. And we postulated in that article that laser perhaps stimulates retinal pigment epithelial cells to grow in a different manner, that then they would produce inhibitory factors or cytokines. Now, in more modern times, it was developed the idea of micropulse delivery of laser. And for those of you who aren't familiar with it, let me sort of give you a rundown because sometimes it gets a little confusing. Remember that micropulse delivers 500 cycles per second, 500 hertz. That means 500 in a second or 50 in a tenth of a second. So that's a lot of pulses. And then with micropulse, you don't use the whole pulse. You take a percentage of the pulse. So for a 5% duty cycle, as you see in the lower part of the slide, you only have 100 microsecond pulse and then at 2 millisecond intervals. So you're delivering a train of pulses. So even if you go to 0.1 second, you're giving them 50 pulses at these very low levels, and they cause less damage. So can lasers stimulate cells without killing them? Because at first we thought, our first hypothesis was, well, maybe if you kill them as they grow back in, they're releasing more inhibitor. And they can do that. But can you still get them to release inhibitor if they're not killed? And it probably is going to be true, and we'll talk about that more. But here are two slides of patients or histologic studies of not patients, but animals with damaged photoreceptors with standard laser on the left, and on the right, subvisible laser with preserved photoreceptors. There have been multiple studies, and this was really started in the 90s with Tom Freiberg, and Jeff Luttrell did a lot of really important work, and I think he's here in the audience, and really demonstrating that you could use this subthreshold laser and not cause problems with visual loss from the laser and still induce the ability to change the disease process, probably by promoting the release of cytokines. And in this study, it was shown that microperimetry and autofluorescence showed no demonstrable damage by following micropulse laser. And here, there's no change in the macular visual field. A lot has been done with the 810 nanometer laser, and we're, again, postulating that that laser stimulates the RPE and maybe adjacent cells to release cytokines that can affect the retina. And a bunch of examples just to show the scope of what we can do, and Khurram and Aaron are going to talk about other specifics, but with CME with branch vein occlusion, here's a pre-treatment eye, here's a post-treatment eye, not very dramatic in this case. DME, pre-treatment, and here post-treatment, and in usually 4 to 6 weeks we can see these kind of effects. Here in branch vein, retinal vein occlusion again, pre-treatment, post-treatment, again, pretty dramatic effects. Central serous retinopathy. Okay, here's slice 1 in pre-treatment, slice 2 that I wanted to show in pre-treatment. Remember, it's slice 1, slice 2, and here, post-treatment, the subretinal fluid is gone in both instances. Radiation retinopathy, which can be a bear to treat. And again, we only have small numbers, so it's hard to really say for certainty what the overall outcome or utility is, but here's a case of ours with pre-treatment radiation retinopathy. Post-treatment, there is improvement. It's not totally resolved, but definitely improvement after about 6 weeks of treatment, after treatment. So the paradigm shift, and where I want to end is the paradigm shift is that laser isn't designed to kill cells and to somehow switch things that way, but and to kill cells and stop them from producing stimulators. But instead, laser stimulates cytokine production. And if we better understand how to use the laser, and we have to really still develop what is the optimal wavelength, optimal energy delivery, optimal spatial delivery, optimal timing, minimize the side effects, optimize synergies. How do we best use them with the other treatments, i.e. drugs in many cases? And the role of laser is a primary treatment, and I think it really has a role there. And in terms of the choosing the best wavelength, we have a lot of options. There's 577, 532, 810, and they all have different characteristics as seen here. This is a slide from Martin Mainster that he published back in the 80s. Again, there's different wavelengths, and you'll hear more about this from the others. But here's a central retinal vein occlusion where we used 577 nanometers subthreshold micropulse, pre and then post. And then spatial distribution is going to be important because we're used to certain spatial distributions that were kind of just made up. I mean, we really have never really done good studies to understand the optimal spatial distribution of laser. But one of the things that's becoming apparent from using subthreshold laser is that sometimes hyperdense application, in other words, application, especially if you're not killing the cells but stimulating them, application of laser, and I don't even want to use the word burns anymore, but laser stimuli right next to one another in a close-knit pattern may actually be the ultimum if you want the whole monolayer to start to change its release of various cytokines. So as we do this paradigm shift, we need to look at other treatments, mostly the injected drugs, and remember that they have a transient action. They really don't last for very long. They're invasive, but however, on the plus side, they have a selective action. We have to remember to balance the side effects, and we have to remember that we have to individualize these treatments for all of our patients. And then laser stimulation has a much longer lasting efficacy. It's non-invasive, but it's going to be less selective than injection of drugs. Again, we have to balance the side effects. And again, we have to individualize. I think that it's nice to talk about big groups of patients, hundreds and thousands of patients, but we also have to remember that every patient is different. We have to understand the disease in the individual. And I think that, again, we need to think about laser in a different way. Not that it just kills cells, but that we can stimulate the cells to release cytokines that can change the balance of the biology or the pathobiology in these eyes. And I have some literature, which will be in the handout when they hand out the slides. It's a literature review of just some small number of the many articles that have been published. And I want to thank you. And next.
Thank you, Dr. Glaser.
And you just click there.
And Dr. Malik.
Okay, I'd like to thank Iridex for allowing me to speak. I also have no conflicts of interest to disclose, nor represent Iridex. I'd like to focus on one aspect of use of micropulse treatments. Many papers have been written about diabetic macular edema and the use of micropulse for treatment of diabetic edema. I'm going to talk in regards to vein occlusions, both BRVO and CRVO, and the possibility of using micropulse for treatment of retinal edema associated in those conditions. So many of us already are aware of what's already available. We'd like to review some of what is known. So the BRVO study came out in 1984. They had waited 3 months before treating. They waited for the vision to be 20/40 or worse, and they did fluoresceins to confirm leakage. They did have positive results showing the percentage of people gaining 2 lines was 65%. So began our use of focal laser burn grid pattern laser treatments for BRVO. The pattern that was used, or is used, for a conventional focal laser is a modified conventional mild intensity, low density. And this would be an aspect of how it's done. And this will play more of a role as I describe micropulse and how I have been using it. So the complications of a grid laser, and Dr. Glaser discusses one aspect. Why does laser work? What exactly are we doing in BRVO, especially if you make a grid pattern? If we're making a grid pattern, how is that helping? So what are we getting with a grid pattern laser? We're getting macular scars, focal scotomas. The scars will expand with time, visual loss. So micropulse may be able to help in this case. So just a brief review. And the BRVO study made a substantial improvement. You all know this. Just to go over the data. The visual letter gains from use of anti-VEGF, ranibizumab, was substantial, 18 letter gains. So as Dr. Glaser also mentioned, as you all know, the injections are repeated monthly. And there are many patients with BRVO or CRVO who are on injection number 10, 15, 17. So you may combine focal laser and Avastin or Lucentis in treatment of them, but nevertheless, perhaps there should be an alternative. So again, those are potential treatment options or a combination thereof. You're well aware of the complications that can rarely occur with injections, endophthalmitis, retinal tears. They're rare but can occur. Focal lasers, I've briefly mentioned, getting the focal scars, the expansion of the scars with time, possibly even CNV. Intravitreal steroids have been used frequently for retinal vein occlusions. Clearly, the cataracts and IOP concerns are of quite a concern. So why MicroPulse? And Dr. Appiah will speak about the use of MicroPulse in 532 for diabetic macular edema. So why use it in a BRVO? It's probably, again, we don't want to cause a burn and the complications of the burn. So the treatment in MicroPulse, and this is what we have found and what has been described by Dr. Luttrell, who's in the back here, as well as other physicians, is the intensity. A lot more burns are placed. There is a high density but low intensity, still using the 5% duty cycle. But you maybe put hundreds, 500 MicroPulse spots in a localized area for treatment of the affected retinal edema. It's just a small pictorial. The pictorial your eyes may be drawn to, but that would be for like a CRVO, if that's considered, or in diffuse diabetes, would be from arcade to arcade. You may put 600 MicroPulse spots, none of which leaves a laser burn, possibly even through the fovea. In a branch retinal vein occlusion, ideally you would cover the area that is seen to be leaking or on the OCT to be showing retinal edema. I have a couple of case examples. These are both patients I've treated within the last 6 months. The first patient has had 9 injections of bevacizumab with positive results on each time, but short-lived, and had the recurrent retinal edema, was treated again, as is recommended in the BRVO study. 2 standard focal lasers had been tried beforehand, but it did not allow for a long-term reduction of retinal edema. So he was treated with MicroPulse, and I put my settings on the bottom there. And this particular patient I actually saw for follow-up on Friday. So I can confirm this was a 6-week follow-up, and I have it was a 4-month follow-up yesterday, and he looks exactly the same without any recurrence of retinal edema. The vision has stayed the same, but you can clearly see the difference on OCT. CRVO is another subject that really has not been written up in the literature very much, the use of MicroPulse in CRVO. We obviously remember the CRVO study that said that focal laser treatment is not of any benefit in treatment of macular edema associated with central retinal vein occlusions. What about MicroPulse? This time we're not causing burns. We're going to treat from arcade to arcade. This has to be studied further, but I'd like to review a little bit with one case report. And again, the CRUISE study again showed how well anti-VEGF is working in treatment of vein occlusions, but they are short-lived. And many treatments need to be provided for patients over and over again. 76-year-old male. He's had 17 bevacizumab injections. Each time a short-lived reduction of retinal edema. He even had one Ozurdex. The Ozurdex was able to allow him to have a reduction for a slightly longer period of time. This is with one treatment of MicroPulse. The vision, as you can see, stayed the same. There was a reduction in retinal edema. CRVO has to be studied in much more detail. Combination treatments will probably be needed, but MicroPulse offers an opportunity to provide a treatment that will cover the macula. I've noticed substantial reduction in fluorescein leakage on angiograms, as well as a reduction on OCT. So I'd like to offer MicroPulse laser treatment as a treatment for BRVO and CRVO that needs to be investigated further with clinical trials.
Thank you. I'm going to concentrate on the 532, which I believe is the latest model offered by Iridex, and almost exclusively in the treatment of diabetic macular edema. We all know that we currently use mostly anti-VEGF with or without steroids to control diabetic macular edema, with laser treatment interspersed as needed. I originally got involved because I was simply frustrated with the frequent injections needed to control the edema, and so were my patients, and actually quite a few threatened not to come back if another treatment wasn't offered. So I got the 532 delivered, and initially I was sort of reluctant because as you do the treatment, you don't see any spots, and there's always this issue of whether you're making any difference. But lo and behold, 3 or 4 weeks later, the patients return and the edema is largely resolved. I'm going to show some of my results. This lady was a 70-year-old white female, very long-standing diabetic, but she had new onset DME in her right eye. And those are the parameters. My parameters are essentially the same except for the applications and the power used. The top slide shows the edema. It was mostly extrafoveal, but you can see that there was some fluid in the subfoveal region. Her vision was 20/40 then, and you can see the macular thickness was 270. I didn't see her again for 3 months, but she came back and the edema had completely resolved, as you see in the lower slide. Vision had improved to 20/30, and she had less edema. This second case was a 66-year-old African-American gentleman with quite refractory DME. He had received several Avastin injections. He had initially responded, but then developed some sort of tachyphylaxis to it, so he wasn't responding anymore. We even injected an Ozurdex with very minimal response. So I offered the MicroPulse to him, and you can see the treatment parameters. I had to use quite a few spots, over 350. And the top slide shows the edema before. It wasn't a whole deal of edema, but it was very difficult to dry up. 4 weeks after treatment, you can see that the edema is getting better, and then 10 weeks later, it's almost completely resolved with improvement in his vision. This is another case of refractory DME, 63-year-old white male. For some reason, he after every Avastin, he would get better. A month later, the edema had recurred. He also had one Ozurdex, to which he responded for a short while, then the edema recurred. So we offered him the MicroPulse, and you can see the extensive edema he had pre-op with 2200 vision and over 400 microns of edema. 3 months later, he was almost completely dry. Vision had improved to 20/60, and the edema had shrunk into 270 microns. This case is one I used a combination of both Avastin and the MicroPulse treatment. His case, this is interesting because he had responded to Avastin before, and he underwent cataract surgery on his right eye, and the edema recurred. He then came back and said he was not interested in any more injections. So I offered him the MicroPulse, and we did that. I told him that the MicroPulse takes a little longer than the Avastin if it's going to work to produce any effect. 10 days later, he came back saying he wasn't seeing any better, so he wanted the Avastin injection, which I did provide. And the top slide shows the edema pre-laser. 10 days later, there was not much resolution. So I added 1.25 milligrams of Avastin, and 3 weeks later he was almost completely dry with concomitant improvement in his vision. Finally, this is another case where I did the conventional Avastin first. I usually add triessence if the edema is quite diffuse to the Avastin, and I get better response that way. I decided to add MicroPulse a few weeks later to get a more lasting effect because, again, this lady had constantly recurring macular edema. The first OCT shows the pre-treatment, And that's when I injected the Avastin. 3 weeks after Avastin, there wasn't much change. If anything at all, there looks like there was a little more edema there. I then delivered the MicroPulse, and 4 months later, the edema had almost completely resolved and the vision had improved to 20/80 plus. So what do I make out of all of this? I'm really happy I got involved because the safety profile of the 532, at least in my hands, is quite high. I've treated over the fovea several times without any visual effect, even if at all. The vision improves when the edema resolves. When you start using the MicroPulse, you don't have to do as many injections, which the patients love a great deal. Most patients will need some sort of combination with Avastin or Lucentis and the laser. Since you're doing fewer injections and more laser, you tend to increase your revenue. The patients are also happier. The MicroPulse doesn't hurt quite as much as the conventional continuous wave treatments. There are few office visits, no scarring. And if you know how to do continuous wave lasers, you shouldn't have any problems learning how to apply the MicroPulse. And I still use the continuous wave for my PRPs, and I use the same system, so it's quite a versatile system. So thank you.
Thank you, Dr. Appiah, and thank you to Drs. Glaser and Malik. This wraps up the presentation portion of our workshop. If you're available, please stick around for further discussion and for a hands-on demonstration of our products. And you can always access more information at our website, iridex.com. And there you can register on our MicroPulse forum, where we have posted a compilation of MicroPulse clinical education material. Thank you again to our panel and to all of you for attending this MicroPulse workshop.